Buprenorphine, it's a slice of the pie. I'll get to this in the end. I have this really fun slide at the end. Why it is a slice of the pie. It's not the only thing. When you're treating substance use disorder, there's a whole lot that you're treating, and just leaning on a medication only, anything really that we treat as people who prescribe medicines, if that's the only thing we're doing, unless, I don't know, maybe it's an infection, it's like, here, take antibiotics, but they should probably rest and not expose themselves to people and other things. So there's other things that need to go in when we're treating people for whatever condition it is. It's not just what comes out of the pill bottle. So buprenorphine, it is a slice of the pie when treating substance use disorder. I have no disclosures. So as we all know, and I do have some of those slides we all have to look at whenever we talk about opioid use disorder, but not too many, I promise. So scope of the problem, about 23% of people exposed to opioids will develop an opioid use disorder, a risk transition that is second only to tobacco. So you hear about like one time you use it and you're hooked, you know, we all probably heard that whenever we were in like DARE programs when we were in elementary school or whatever. But opioids, they're pretty serious. So tobacco, much higher profile for you start, it's hard to stop. Same type of thing happens with opioids. But then you also throw in things like genetic, psychosocial factors, including sexual or physical abuse, and that just really increases the likelihood of someone developing an issue with any substance, but in particular opioids, considering 23% of people exposed to them will develop an opioid use disorder. So there was a study done, a lot of people getting opioid prescriptions, and specifically looking at the 16 to 18-year-old. And those with pre-existing psychiatric problems, anxiety, mood, neurodevelopmental, sleep, non-opioid substance use disorder. So maybe it's a cannabinoid or it's an alcohol or some other use disorder, more likely to be prescribed long-term. So whether that was, you know, which came first, you know, the apple, the cart, the chicken, the egg, whichever, were these individuals who would return seeking more opioid prescriptions because they did have an underlying mood disorder or anxiety, and were continued on opioids long-term because they came complaining of pain. But these are also individuals that have other conditions that predispose them to an increased risk of developing an opioid use disorder. And anybody who's exposed to an opioid consistently for that many days is going to go through withdrawal. So you're even talking about physiologic dependence as well, which is going to be an issue. So just knowing that 16 to 18-year-olds, there was a lot of opioids written for that age group when looking in this study. That's important when we start to think about, you know, the people that we're working with. When did this start? So if we're thinking about how are we going to turn the tide on opioid use disorder, where do we need to go? And, you know, they tried, it wasn't the greatest way. It's like, just say no to drugs, and the, you know, DARE program and all that, like, just don't do it. Like, oh, that'd be great if I had, you know, a fairy tale life. But a lot of the people we work with have been exposed to substances, and this is any substance, this wonderful little graph we're looking at, any substance, but the age at which individuals who were seeking treatment. So again, you're kind of looking at some, you know, refining slices of who we're looking at here. So the people who are not in treatment, you know, the number is going to be even bigger, right? Because these are just people who are entering into treatment facilities. At what age did you start using substances in a non-intended fashion? 30%, so 40% when you add them together, under age 14. So it's a lot of people who started it way before a lot of people even thinking about we need to be intervening and providing more positive experiences, positive structure. So largest age group just by itself, the 2 years, 3 years, 15 to 17. So it's our middle school and high school students where initiation is starting, who end up in treatment later on between 18 and 30. So the point of that is we're seeing tip of the iceberg type stuff, which is why it's important to be curious, inquisitive, and empathetic whenever we're working with people, just in general, but especially when we're thinking about substance use disorder and the risk that someone may be in a high risk situation for developing a substance use disorder, opioid use disorder, or already kind of in the weeds with that. So Robert Graham Center loves to put out all these wonderful papers, like statement papers. This is out of one of them. Growing opioid use disorder disproportionately impacts rural areas. where we don't have that many physicians, and we don't have that many physicians who are willing to write buprenorphine. So when you start looking again, kind of like, thinning it down, like who's doing this? Where are they doing this? Where are physicians in general? What type of physicians are there? Are any of them writing buprenorphine? Because we know it is one of the 3 FDA-approved medications for opioid use disorder. So among the physicians approved to prescribe buprenorphine, family physicians are the most likely to work in rural areas. So this is a policy study on family medicine and primary care. This was written before the CARA Act, and that's the one where nurse practitioners, physician assistants, certified nurse anesthetists, and certified nurse midwives are now able to write buprenorphine. So some of this may have shifted, and I don't have slides on that, and I need to get updated slides on that, but this is looking specifically at physicians, most likely to be family medicine docs out in rural areas. And they are actually, and I don't have that slide in this set. If you look at it though, they are the more likely, even when you look at psychiatrists, they are more likely to be the ones who prescribe buprenorphine when it comes to just looking at any specialty of physicians. Available treatments for opioid use disorder, pharmacotherapy and behavioral therapies. Gold standard is medication-assisted treatment. So that means a prescription, which could be methadone, buprenorphine, or naltrexone. But that is combined with some form of counseling or behavioral therapy. So gold standard is those 2 things. Like I said, buprenorphine is a slice of the pie. You need more than one ingredient here to actually have something meaningful and can move someone towards long-term recovery. Can someone calm down the chaos with just medication? Yes, but then job is not done. It's not just about calming chaos, so they aren't chasing something illicit on the street and being exposed to fentanyl. So a lot of people come from the thought of abstinence is the way to do this. This is the only way to do it. This is the goal for everyone. So this is number of people, percent of people after an amount of time of achieving abstinence who remain abstinent from the substances listed here over that amount of time. And it drops off precipitously. The more time that passes, the more it drops off. It does level off after about 6 months, but that's a lot of people who have returned to use. And it have increased the risk of overdose and death. So this is a fun little graph. Basically, there's a lot of words and there's a bunch of little wiggly lines on here, but they did a study. They had some people on buprenorphine naloxone, noted they were abstinent at the end of treatment period. Medication was stopped. And then a very large percent of people went back to using. And then when they did an 18-month follow-up with these individuals, they found a good portion of these people had gone back to an MOUD. They'd gone back on buprenorphine, or they had engaged in some type of MAT program somewhere. And then that percent, that 8.6, where abstinence out of the people in the study, only 8.6 were still abstinent at their follow-up point. When they followed up in 18 months, those that had gotten back into treatment, the abstinence rate went back up. A lot of people will say, and you guys have probably heard this too, you're just substituting one drug for another drug, and all they're seeing is a substance. They're not seeing behavior. A prescription prescribed by a provider that is licensed to prescribe that, taken to a pharmacy, FDA-approved medication, dispensed, taken as directed, is not an addiction, because an addiction is behavior. Substance use disorder is about the behavior and not the substance that's involved. So this is not trading one substance for another. This is engaging in treatment, and you see changes in behavior. And abstinence, even though someone on buprenorphine is taking an opioid, they are not taking something illicitly or an illicit substance. So in general, when you think about the work that you do with buprenorphine or any of the MOUDs, it's good for your patients. Abstinence from illicit opiates or any other substances, because when you go looking for one thing, you're likely to find other things. If you don't need to go looking because your opioid cravings are controlled, and when they don't have opioids, but all they have is meth or cocaine, or maybe they have an opioid and it's called fentanyl, you're decreasing your risks of what you're being exposed to. Harm reduction in relationships, employment, and legal consequences. So we're improving our relationships. We're actually we're engaging in gainful employment, and we're not running afoul of DCS or the police or our parole officer or probation officer. Decreased health needs. So studies looking at utilization of ERs and inpatient admissions, those patients who are maintained on MOUDs decreased utilization of those services. Overall, patients report a better sense of quality of life. And I think you can imagine why, with some of the things I've been talking about, and treatment flexibility and safety compared to other MATs. So we'll get there some slides about this in a minute. How you can access buprenorphine compared to methadone, and then safety profiles of methadone and naltrexone. So one of the things that we need to be thinking about is accessing MAT and thinking about our emergency departments, because that's where a lot of people are interfacing with healthcare providers, where they've come in because of an overdose, they've come in because of an abscess, they've come in because they're septic. So it's a wonderful place to interact with patients and possibly offer an opportunity, something else for them, treatment-wise, than just treated the sepsis, sent them out. If you're working in the ER, you do not need an X waiver. We're actually in a place and time now where you don't need an X waiver, which is interesting if you don't prescribe for more than 30 people. But if you're intending to prescribe for more than that, and then state rules may dictate what you do depending on what state you're in. In Tennessee, I think it's okay. I think it's just good to get the training to get your X waiver. Maybe because I'm a trainer for an X waiver, but so maybe that's a little bit of a disclosure. I think X waivers are great because I train people how to, I do the training to get your X waiver, but working in the ER, you actually can write, like as an outpatient, they can come in, have it, go out, but you can also, you can do that for 3 days. If you have someone admitted on inpatient, you don't need an X waiver either. And that's more than 3 days. So if you've got an inpatient, you can continue the medication, even if it's methadone. But for buprenorphine, you can have them come into your ER. And I've seen ERs do this for things like, they're treating somebody for an ear infection, and literally they come in and get IM Rocephin for 3 days in a row in the ER. So sometimes our ERs are not emergency, they're just continuity of care for some patients. They can bridge someone 3 days on buprenorphine until they get into a clinic for a continuing prescription. Treatment retention and decreased illicit opioid use. Those who are on buprenorphine, we see people staying engaged in treatment longer than those who are in an abstinence-based program. You also see benefits of MAT resulting in decreased mortality. No treatment is the red bar. Medication-assisted treatment starts looking a lot like the green general population as far as all-cause mortality. So it's also good for providers. So a lot of times, back in the day when people would come in, and I can remember in my office, and this may be something some of you still experience, where you have patients coming in and they need opioids, they need more opioids, they're transferring care from somebody who is writing them all these opioids. And we've got rules in place now and laws that kind of help us turn down how much of that we've been experiencing in the last several years. But sometimes there's a feeling of, you're kind of out there, and you're being manipulated, you're working with patients who are antagonistic. It can set up a very uncomfortable situation in your office. But when you have a patient who comes in, is acting in ways that make you think that there's an underlying opioid use disorder, you have something to talk about with them instead of just being like, well, I can't do that, but I can do this. And they're just mad at you and they storm out and you've not gotten to do anything. You can start having a conversation. You can start that empathetic, understanding, non-judgmental engagement with a patient. And if you're like, this looks and sounds like you may have an issue with an opioid use disorder, and then the next thing you know, you're like, well, we can do something about that. I can offer you treatment for that because I, in my office, I can provide treatment for that. So there's less feeling of being manipulated or helpless in the context of someone with an opioid use disorder. You see your patients get better. There is nothing more amazing than to see a patient when you first start with them and then roll the tape forward a month. And you're like, are you sure you're the same person? Roll that tape forward a year. And you're like, I know you're the same person, but you look completely different. Like, this is a whole different countenance. The way you carry yourself is different. The sense of pride I feel when I'm in the room with you, not like that. It was not there at all a year ago. So seeing your patients get better over time is really rewarding for us as providers. And when we think about burnout, that's a great cure and preventative for burnout is seeing your patients get better. just that short-term and long-term sense of satisfaction for us as providers, because our experience as providers is really kind of important, because we need to keep showing up every day and doing the good work. Focusing on a large issue that has negative impact on the patient's global existence, but also for our community as well. We're helping our community get better when we treat people who have an opioid use disorder. Nobody's ever said thank you for controlling my blood pressure yet to date. I've not had a patient, but I have had patients tell me thank you for being here and providing them with medication, giving them a place to talk, giving them a place to feel accepted and heard. I do get thank yous for that, and not uncommon. It's also good for our community. There's reduced crime. We get people out of that rotation of in and out of the penal system. So it's just, it's better overall for our communities, because we need people in our communities raising their children and not spending time in detention centers, prisons, or jails. So these are some of the formulations. You can get it as a film. You can get it as a tablet. The Motto product, Subutex, and then the Buprenorphine plus naloxone, that is Subzolve or Suboxone. You can get those as a film as well, but then there's also the depot buprenorphine. I don't have the rod. There is Probufene, I think is the name. One of our pharmacists can correct me. It's like a rod, just like a Nexplanon that goes into the arm as an implantable. Brixadi, I think, is maybe coming out next year, so it's not quite yet available on the market, but Sublocade is currently available as far as a monthly injection. The Brixadi, I believe they're going to have weekly as well as monthly options when that one comes out. So buprenorphine is a partial morphine opioid receptor. That's what MOR is. I always look at that and I'm like, morphine? No, morphine, mu opioid receptor agonist, I just did it, and a weak kappa opioid receptor antagonist. When you look at your full mu agonist opioids like heroin, fentanyl, oxycodone, those guys are actually agonists at the kappa opioid receptor, and that results in depressive symptoms. So the kappa opioid receptor antagonistic behaviors of buprenorphine, I think, is important, but we don't talk about that a lot because I don't think a lot of studies are looking at that. And again, our pharmacy friends may be able to say more about that. But there's some thought that there may be almost like a mood modulating or an antidepressant effect of buprenorphine because of that kappa opioid receptor antagonism. In our clinically used doses, it acts like a typical mu opioid receptor agonist. So it activates, it interacts with that receptor, but it doesn't activate it as strongly as things like heroin or oxycodone will do. That's that partial agonism at that receptor. It does reach a plateau, which is nice. So I had a patient that I was doing, and I do home inductions with all my patients. But he was doing his home induction and he came back and he ran out a couple of days early. And I'm like, how much were you taking? He was taking up to 48 milligrams of buprenorphine. FDA regulations is up to 32. And I'm like, no, you took too much. But he had no ill effects of it because it does hit a plateau. And it's about after 32 milligrams that it hits that plateau. And then higher doses is when you do get that kappa opioid receptor antagonism starting to kick in. Reduces the abuse potential. So people, like, I'm not quite certain what he was trying to get done, whether he thought it was going to keep doing something and he was trying to get something out of it and it never happened. Or if he thought, as many people do, more must be better. But you hit that plateau, you're not getting anything more out of it. So even if you take 48 milligrams, nothing's really happening. Decreasing the risk of overdose. It doesn't have that respiratory suppression that other full mu agonist opioids do, and it has a slow dissociation from opioid receptors, which means that you can really play around with how you dose it with patients. When it comes to tapering it off, we'll actually do kind of an every other day thing. Like when I get somebody down, like maybe we're taking 1 milligram every other day. I've even worked with people where we're spreading it out 2 and 3 days, like just increasing the time in between. So it has a very flexible dosing regimen. I just said these words. Sublingual administration, we hit those peak levels in about 30 to 60 minutes. Half-life, though, is up to 37 hours. It can precipitate a withdrawal with other full mu agonist opioids. So it binds very strongly to that receptor. It doesn't titillate it very much, but it binds very strongly. So it will go in and push off others like morphine, like heroin. And so if someone does start an induction of buprenorphine a little early, they can have a precipitated withdrawal. I usually start people around 2 to 4 milligrams, and then we follow it up with an additional dose. And typically I'll have people 8 to 12 on their first day, tell them to repeat that on the second day, and then taking them up. In this slide, it says 24 milligrams. I have taken people all the way up to 32. It has a lot to do with what their tolerance pre-starting treatment is like. And when I have patients who've been using a few grams of heroin a day, I may need to take them to 32 in the beginning to help them stabilize, and then we'll come back down to more of a maintenance dose. So there's some tinkering around in the beginning where we have to titrate to a dose where we get rid of sickness, and then we have to get rid of cravings, and then we kind of settle down at more of a continuation. This is what we're doing week after week, month after month, kind of a dose. These slides are available later on, and I'll let you look at all of those. I'm not reading all these words, don't worry. Side effects, these are not uncommon. A lot of people will talk about that they can't tolerate Suboxone. It's the combination product because of a lot of things that are actually side effects and not allergies. Given time and given other medications to help with side effects, people often will get over the hump. But sometimes they can't get past the headache, the dry mouth. The sweating is one that doesn't come up often, but I have had patients who have excessive sweating. I had a patient recently who just went through some excessive sweating and then it just stopped. And she'd actually been on buprenorphine for a while. So I don't know if the sweating was related to that or something else, but it resolves spontaneously on its own. And that's usually what happens with a lot of medications we give patients. It's like, how do we resolve side effects? Give it time. And if after a few months it's still intolerable, then we can think about something else. But we can also support the side effects with other medications along the way. When I mentioned before, buprenorphine, as far as its risk profile, is a lot lower than some of our other MAT medications, our MOUD meds. Prolonged QT interval is what happens with methadone. We need a baseline EKG for methadone, and then you want to follow that up periodically. Buprenorphine is not associated with that. Also has a lower overdose risk than methadone because methadone is a full opioid, a full mu agonist opioid agonist, full mu opioid receptor agonist. I'm talking too fast even for myself. And when you have that full mu opioid receptor agonism, like from methadone, that's where you will get respiratory suppression, and it does not have that plateau effect like buprenorphine does. So there's a risk of overdose with methadone. These are different formulations that are available. The injectables and implant, those are all monoproduct. So if you do have patients that are just, they can't get on board with the idea of using a sublingual combination product, buprenorphine, naloxone, offering them an injectable is a really nice thing to be able to do. One of the risks with buprenorphine people think about is diversion. And when you're using an implantable, you really decrease takeaway that potential. So advantages of buprenorphine for treating opioid use disorder: fully participate in treatment activities without having to change their environment. Granted, we want some things in their environment to change, like maybe we need to not be with certain people, maybe we need better housing, but we don't have to send them someplace far away to receive this treatment. We can do it in their own environment, so they learn how to manage their environment because we do not yet have a pill to take care of people's environment. So that's work that we've got to do with our patients and helping them find housing, find work, get services that they need online. The limited potential for overdose, minimal subjective effects following a dose. I tend to have patients, that actually what I hear more often is not that they're sedated from their buprenorphine. They actually feel like I do after I've had a cup of coffee in the morning, feel like I'm ready to go and get my day started. They feel appropriate, they feel normal. And quite honestly, that's the main thing I hear from patients when I do an induction and I'm checking on them, how are we doing, where are we getting? And as soon as they tell me they feel normal, literally quotes, how are you feeling today? I feel normal. And it's like, I feel like it's a new, this is amazing thing that I'm feeling. I feel normal. I know we've gotten on the right dose. They're not sedated. They're not, they feel normal. They feel okay. It also enhances retention and treatment. We have studies that show us that. I had a graph. Reduces return to use rates, prevents withdrawal. blocks the euphoric effects of other opioids. So it's strong enough to shove other opioids off the receptor and do that precipitated withdrawal. When it is on board, it's sitting there and nobody else is really pushing it off. Naloxone will, naltrexone will, but none of the other opioids will really shove buprenorphine off of that receptor and take its spot. If the buprenorphine dissociates like it normally does, somebody else can move in, a full mu agonist can move in and sit on that spot. But with buprenorphine sitting there, nothing else is going to push it off. And I've had patients when they have had return to use, and I'm like, well, what happened? How was it? They're like, it was a waste of money. I felt nothing. So there is also a little bit of negative reinforcement. And I didn't get what I thought I was going to get by using. It doesn't do for me what it used to do. So why am I going to waste my money again? Available for use in an office setting. They don't have to go someplace far away. They don't have to go to someplace special. They don't have to go to someplace that has a big old sign on the front that is like, this is what we do here. And anybody whose car you see in the parking lot, this is why they're here. It allows more privacy and anonymity, which some people really want, especially in small towns. Or in places where they know they're going to be recognized, because maybe it's the big wig that is on the television telling us all kinds of things like how many car accidents there were today. Because there are people, all walks of life, who have issues with substances, and they may be recognized because people know their vehicle. Discourages intravenous use. It allows for take-home dosing because it's a prescription they're going to go get from the pharmacy. So obviously they're going to do that at home. Disadvantages, it can cost more. It's actually gotten a lot better. A number of my patients who have TennCare, they're paying $1.50 copay for their prescription, and that is affordable for most of my patients. They do remain physically dependent because it is an opioid, so that hasn't changed. That's why some people really want naltrexone, which we're going to talk about in 2 weeks, because they do not want to be physically dependent on an opioid anymore. And if you've got the right kind of urine toxicology screen, it will pick up the buprenorphine. It won't test positive for morphine. It won't test positive for oxycodone. It won't test positive for methadone. It will only test positive for buprenorphine. So whoever's doing a toxicology, they have to have that strip on their urine cup or spit swab or whatever they're doing to see it, but it is detectable on a toxicology screen if it's testing for the appropriate substance. And then there is that potential for diversion. But again, if we can do the implantables, it kind of takes that off the table. So here's my fun pie slide, which means we're at the end of my talk. It is a piece of the pie. We need to provide other supportive services for those who are providing opioid use disorder and substance use disorder, any of them, care to parenting classes, substance use counseling, general counseling, family counseling. Get everybody in here and let's talk about it. Let's all be supportive of one another, have a more positive home environment. Counseling for co-occurring diagnoses, diagnosing co-occurring diagnoses, treating them, providing the counseling, job training, skills development. We're wanting to return people to the life they want to live, showing them that it's possible, that the potential is there, and that we can provide them with the services that they need in order to enable that to happen. And sometimes to make the pie full of pie, because I mean, really, if you can have this pie, do you want just one slice? I want the whole thing. Buprenorphine can be a part of that pie, and really, really get your belly full of some good care and, fuel the fires and get you going in the right direction. So MOUD, MAT, however you want to talk about it, medication for substance use disorder can really make a difference in how our patients respond to treatment. And then those are some references. Oh, do not doubt that I went over, because watching the clock when I talk is impossible. So any questions, any comments? And I referred a few times to my pharmacy friend, so please pipe in if you have anything to add to that, especially the farm part that I just blasted through.
Dr. Troxler, I thought you were spot on. I guess I have had issues with patients precipitating withdrawal with Suboxone or buprenorphine, and also the concern about tapering off. A lot of them have experienced the Suboxone withdrawal, and that's something they don't want to go through again. I guess in order to combat that, I have a question that I've been reading about microdosing buprenorphine. So allowing the patient to continue to use a full opioid agonist and using small doses of buprenorphine in order to get them to a therapeutic dose quickly while they're still using. Do you have any experience with that? I mean, to me, that's more of just an anecdote than actual practice.
It is not something I have done. I have seen lots of different protocols for how to do it, including like transitioning somebody from methadone to buprenorphine. And it looks like something that you need to be able to have a patient access your office frequently, like every day for several days. They need to be in your office in order to do this, because I don't think it's something you want them doing at home and unobserved. Is it something, so if you need, and for me, yeah, it is. I've heard other people talk about it. It is not something I have done. And there's a part of me that just wonders, is this, and anybody else please chime in, but part of me wonders if it's a little bit kind of, it's a different way to do it. It kind of avoids some of that, you know, where someone is coming off of something and that fear of experiencing withdrawal, but avoiding the precipitated withdrawal. Because one of the things that you can do in that situation, because microdosing seems to be a much longer, intensive involvement with the patient. When you get precipitous withdrawal, you can actually continue to build on the buprenorphine so that you override that precipitated withdrawal by getting more buprenorphine in the system. So it's almost like you've got microdosing is one way to do it, and you've got macro dosing is another way to do it. So if you have a precipitated withdrawal, you can be like, because one of the things you don't want to do is abandon the process, because the likelihood of somebody coming back and trying that again is very low. So if you have someone who's having precipitated withdrawal, you just start bringing in the buprenorphine more frequently. And so instead of waiting an hour, 2 hours, 3 hours, whatever, if you precipitated a withdrawal, you just have them take another dose and take another dose and take another dose until you get on top of it, because you've got enough buprenorphine in the system. You've shoved off all of the full mu agonist opioid, and you've got the buprenorphine sitting on those, because that's what it does. When people do that induction, they're stopping the sickness. We're just having to do it really fast.
Yeah,
I've had more experience with that than microdosing, but those are two different ways to go about it. And there are a lot more people talking about microdosing.
great. Thank you. You know, I've heard about both methods. Thank you.
You're welcome. That process of coming off of the Suboxone 2, that withdrawal, yes, that's something we hear about a lot. And it seems to be when you get to the really bitty doses that people struggle with coming off of the buprenorphine. And that is actually when we do that transition from this dose to a lower dose, we increase the frequency of visits they have with us, really increasing counseling. And also before we start, when we get to those really low numbers, really increasing the intensity of their counseling. Because I have found the mental preparedness has made a bigger difference in that final cessation. We have the support meds, things like the clonidine, Zofran, loperamide, all that baclofen, all that stuff on board, but it's being mentally prepared and just planning for it. Like, you're going to feel like crap X amount of time, put it on the calendar, have it be a vacation, so that we've prepared for it. That tends to make a difference.